Could you please introduce Dr. Sholler for the first speakers?
Good morning, everybody. It's my honor to have a chance to have an exchange with you today under this platform. So the first speaker will be Professor Giselle Sholler. So Professor Sholler graduated from New York's College of Medicine, and then subsequently she received her training in the Hartford Children's Hospital under the Brown University. So after that, she has been working in the Levant Children's Hospital in North Carolina and also Helen DeVos Children's Hospital in Michigan. And then currently she's the director of the Pediatric Hematology Oncology Program in the Penn State Health Children's Hospital. And then I think one of the major role that she's having is she's the founder of the Big Children Cancer Research Consortium, which includes 55 hospitals, right? So this is a great achievement. So of course, in terms of scientifics and also clinical achievement, Dr. Sholler is the one that pioneered and using this polyamine depletion therapy called the DFMO. And then I'm sure she will enlighten us today with this information. Thank you. Dr. Giselle Sholler, please. Yeah.
Thank you. And thank you for inviting me here to join all of you tonight, or this morning, I guess, where you are. It's quite an honor to join this distinguished group, and I'm very excited to share my research with you. Shall I start to share my screen then? Someone else is sharing request. Is this okay for me to start my screen? To get to the beginning. And okay. Push this down. Thank you again. Is everyone hearing me okay? Can you see my slides?
Yes, we can see you and also the slides, okay.
Great. Thank you again for inviting me to talk with you tonight. I'm going to talk about neuroblastoma and our role in bringing DFMO and polyamine depleting therapy into this disease, and just a few slides as to how we got here. So neuroblastoma, as you all know, is the most common solid tumor, non-brain tumor, solid tumor in children. We see this in about 1 in 7,000 children, generally less than 15 years of age. The average diagnosis being at 22 months, although we see two different populations of patients, generally less than a year, have very good outcome and tend to be more either low risk or intermediate risk, as you can see from the slides, having excellent outcomes. Whereas those children diagnosed around 3 to 5 years of age are often metastatic at diagnosis and characterized as high-risk neuroblastoma. And this risk category is very important in determining outcome. As we can see historically, the high-risk neuroblastoma has a less than 40% event-free survival rate. This is a little bit old data, but this is where I started from about 20 years ago, looking at taking care of children with high-risk neuroblastoma and seeing this terrible outcome and what could we do. And you can see one of the biggest problem is in that first 2 years, there is such a significant relapse rate. While we're able to get children often into remission using our standard high-risk neuroblastoma therapy, which includes induction, chemotherapy, and surgical resection at some point during induction, followed by, the goal for the end of induction is that most kids are in remission or as close to remission as we can, to then consolidate that remission with either high-dose chemotherapy or a stem cell transplant, either single or tandem transplant, depending on your location in the world. And then following that with radiation therapy to the primary sites, and then any remaining sites of active disease. Often if there's 1 or 2 bone spots, that we will try and really radiate those remaining areas of disease to really consolidate into a full remission. This was often followed with immunotherapy. This was studied here in the US in around 2010 to 2014 by adding anti-GD2 antibody, dinutuximab, alongside our differentiation agent, cisretinoic acid. And this was really the COG landmark study AMBL0032, which resulted in us now using immunotherapy as standard of care. Because as we can see in the results during that study, we saw we saw a big difference in both overall survival and event-free survival, with the especially the 4-year overall survival increasing from 56% to 72%, and the 4-year event-free survival improving from that 44% to 54%. But still, about 50% are relapsing. So we still need to do better. And as you can see, it's in that first 2-year time frame where the biggest drop and where most of our children relapse is in that first 2 years. So how can we prevent relapse? Again, most occurring within the first 2 years. And historically, in the US, most relapse patients who do relapse die within 5 years after that time point. And so DFMO is a medication that we studied focusing on relapse prevention. So very different than other chemotherapy where you're really trying to kill tumor cells. We were really looking as to why do cancers relapse? Cancers relapse because cancer stem cells that remain in the body after chemotherapy and radiation are those cells that are relatively refractory to cancer treatment, mostly because they're more of a quiescent cell. Cancer stem cells account for about 1% to 2% of the cancer population, cell population. And the figure on the left kind of shows that red cell as the cancer stem cell, both of them. And you can see that you give therapy, and on the top, if it's chemotherapy, really therapy that's affecting rapidly dividing cells, intercalating into the DNA, causes a tumor shrinkage, but allows the cancer stem cell to remain, which then can cause the relapse. Whereas if we were in studies where they show that they can target the cancer stem cells themselves, even with remaining cells there, can cause tumor shrinkage and tumor regression. To measure the cancer stem cells in the lab, you can separate out each of the cells of the tumor. We do this often in 96 well plates, and you can see that the wells that have a tumor cancer stem cell present will be able to recapitulate the tumor similar to the primary tumor, whereas the cells that are put into wells that are not cancer stem cells will really just die on their own because they have limited self-renewal activity. So that's important for the studies that we're going to show. Now, in the LIN, what's an important pathway in stem cell self-renewal is the LIN28 pathway. What's been shown is that cells that have high LIN28 and low LET7, because they balance each other, tend to have overgrowth and then transformation into a tumor. If you can decrease the LIN28 in the cell, increase the LET7, it reverses the stem cell phenotype to a more differentiated phenotype, as well as tumor suppression, growth retardation, and low glucose metabolism, so a decrease in the PET scan. So we looked at this LIN28 LET7 pathway, and DFMO is actually the medication that we're looking at is an irreversible inhibitor of ODC, ornithine decarboxylase, which is important in regulating polyamines in cells. Polyamines are important for cell proliferation and differentiation. It decreases AIF5A hypocyanation, which is important for activation of LIN28. If we can decrease the AIF5A, we can decrease LIN28 in cells. That can increase LET7, and LET7 is an important regulator of MYC-N. So if we can increase LET7 microRNA, it can then suppress MYC-N, as well as suppressing glycolytic metabolism, which is really important in neuroblastoma. So this targets both the LIN28 cancer stem cell pathway as well as the MYC-N, which is important for neuroblastoma cell growth and division as well. And many others have studied this, showing the high LIN28 expression is a risk factor in neuroblastoma. And many of the tumor cells that we've sequenced, we see that high LIN28 in upfront neuroblastoma. So we wanted to look and see if DFMO decreased this pathway. And these are two different neuroblastoma cell lines, BE2C and SMSR. We treated them for 48 or 72 hours with increasing doses of DFMO. And we were able to see in both of the cell lines, we saw a decrease in ODC, as well as a significant decrease in LIN28, significant decrease in MYC-N. And then below that, those are cancer stem cell markers, SOX2, NANOG, CXCR4, and KLF4, all of them high in cancer stem cells, all decrease with the treatment of DFMO. We wanted to see, was DFMO causing some of the physiologic effects of suppressing the cancer stem cells, such as inducing senescence in these, which is a cell arrest. And we saw that with 5 different neuroblastoma cell lines. As we increased DFMO concentration, both at 48 and 72 hours, the cells underwent senescence. What's really important is that historical studies prior to this, looking at DFMO, looked at very high concentrations to cause cell death in neuroblastoma. The concentrations of DFMO that cause cell death in neuroblastoma cells are much higher than is achievable in humans. It's not a cytotoxic drug in our patients, but at these low levels, that 100 to 500 micromolar, that's the pharmacokinetic level that we can see in patients. So at the levels that we can achieve in patients, what we're inducing is targeting the cancer stem cells and inducing senescence in the neuroblastoma cells. We were also able to show that even at that 150 micromolar, we were able to induce inhibition of neurosphere formation. So as I mentioned earlier, in looking at cancer stem cells, if you put 1 cell per well in 96-well plate, only the wells that have a cancer stem cell will be able to grow and recapitulate a tumor. What we're able to see in the red is with no DFMO, and as we increase the concentration of DFMO down to the green, we can see that there's a significant decrease in the number of neurospheres that are formed in the wells. And so the DFMO is really recapitulating the behavior that we expect. It's inhibiting those neurospheres, those cancer stem cells, to form little tumors in the wells. So in summary, at the doses used and achievable in humans, DFMO inhibits ODC, decreases polyamines, results in G1 cell cycle arrest and senescence of the cancer cells, restores Lin28-7 balance, inhibiting again in that process, and then suppressing neurosphere formation, resulting in a cytostatic response in neuroblastoma and targeting those cancer stem cells. So as we were doing this work, we did our first phase 1 trial of DFMO in neuroblastoma. It was interesting. For our phase 1 trial here in the US, we need to treat patients who were refractory, relapsed patients who had no curative options. So these were patients with active disease. Again, not exactly the patient population we wanted to target in the treatment schema, preventing relapse. But first we had to evaluate doses in a safety study, which required a phase 1 trial. And so we did 4 different dose levels and found there was no toxicities, no DLTs at these dose levels. We could go higher, and other studies have, and we have actually gone higher since, for patients with brain tumors. But in neuroblastoma, these 4 doses were found to be safe. We gave cycles of 21 days in duration. The first cycle was DFMO alone for 21 days. And then we combined it in combination with low-dose oral etoposide, again, because these patients were patients with active disease. The low-dose oral etoposide was given on days 1 through 14, starting in cycle 2 of a 21-day cycle. What we found on this study, this is our only phase 1 study, that these 2 children came on with active disease. The little girl in the middle was told she had 6 months to live because of the amount of bony disease of neuroblastoma she had. The little boy on the left holding the bottle had a baseball-sized tumor in his chest that was not operable. And the other little boy had a mixture of a paraspinal soft tissue as well as bone. But these all children, while they had been told they were incurable, they were on DFMO for over 2 years. We did see decrease in PET scans, so showing that decrease in the glycolytic activity of their tumors, and their tumors after the boy in the withholding the bottle, we actually kept him on for 2.5 years because he was patient number 3 on the study. We were not expecting to see him still running around and doing well. At that point, we stopped the DFMO, and we saw his tumor continue to regress even after stopping treatment, again, suggesting that we were targeting the cancer stem cell, allowing the tumor to regress. And the other 2 children, we kept on for 2 years. The 2 little boys are in college today, 20 years old, and the little girl is in high school. And so we wanted to, again, prior to doing the phase 2 study, take a look at I'm going to skip to this one here. We did 2 different mouse models with neuroblastoma, but essentially this is what we want to recapitulate in the phase 2 trial. These were mice injected with very small amounts of neuroblastoma cells, either 10, 50, or 100 of the BE2Cs, because they're a little more tumorigenic, on 50 and 1,500. So normally in a mouse model, to create a tumor, you inject 1 million cells. This is a very small number of cells injected, kind of mimicking a minimal residual disease. At the end of treatment, they would have just a little bit of neuroblastoma in the mice. And then one group of mice was given regular drinking water. The other group of mice was given 2% DFMO in the drinking water. And we can see that the mice that were given DFMO were not relapsing at the same rate as the mice that were given regular drinking water. And many of these mice were cured and never relapsed. And so that brought us to our phase 2 clinical trial, where we wanted to add DFMO to the end of upfront treatment. So the patients were receiving here in the US chemotherapy, surgery, transplant, radiation, antibody therapy, and cisretinoic acid. And then within 120 days, they had to enroll on study DFMO for about 2 years. Most patients enrolled at about 60 days from completion. After completing therapy, getting their scans. This is one of our little girls getting her very first dose of DFMO in a little bit of applesauce, I think. So the primary endpoint was to look at event-free survival, and then overall secondary endpoint was overall survival. Just a reminder again, the time since the end of immunotherapy is here. So at this point in time is when patients then started DFMO, and we followed them out. But we wanted to see that this 2-year time point, again, reminder, that's the highest risk of relapse. What we found was that this is where our historical control estimate was, and that we improved significantly. The 2-year event-free survival was 85% of patients remaining in remission at 2 years, as opposed to the larger drop that we saw prior. And then what was interesting is that if patients made it 2 years, there was a couple of relapse. Most patients did not relapse after that. And so the 4-year event-free survival was very similar to the 2-year at 83%. One question that many people ask is this really for MYC-N or MYC-N amplified patients only, or for both? What we saw was both MYC-N amplified and non-amplified do as well. So both patients were in the same cohort, both increased compared to their historical event-free survival. Compared to overall survival, this was a significant increase from what expected, with a 97 and 95% of patients 4 years after completion of immunotherapy. This really led us to a lot of discussions with the FDA, given what the expected historical control and a significant number of children alive versus not alive. And so in those discussions with the FDA, was there a fit for purpose external control? Could we have a comparison that would be appropriate to compare to? What was interesting was on the DFMO trial, patients had followed standard of care. Most patients had actually been enrolled on ANBL0032, and so were closely monitored on a clinical trial, and came directly from that trial to our trial. So were there patients on ANBL0032 that completed standard of care, but did not get DFMO? And we wanted to see, could we compare those patients? When we were able to get the raw data from the Children's Oncology Group, there were close to 1,500 patients on that clinical trial, but about 852 completed that trial and met all inclusion-exclusion criteria to have enrolled on DFMO, but they did not. And so that was a similar population. We first looked at so we had our 92 patients that had enrolled on ANBL0032 but did get DFMO versus those that enrolled and would have qualified for our study but did not enroll. And the populations were similar in terms of all kind of the risk categories. And when our statisticians did the analysis, they did see what we expected, a significant improvement. At 4 years, we had 84% of patients in remission versus 72% without DFMO. And overall survival was 96% versus 84% without DFMO, suggesting 12% of children alive that should not be. And when we looked at the safety population, so far this time we had looked at 360 patients. The main side effect with DFMO was hearing loss. It is a reversible hearing loss if we're able to stop it early and check and lower the dose. It's dose dependent. We definitely see a significantly higher number of hearing loss, a proportion closer to 25% when we do a much higher dose for brain tumors at 2,500 milligrams per meter squared. And the other things we did see is increase in AST, ALT, but really not high enough to halt the DFMO and seems to kind of come up and go back down on its own. Not clinically relevant, the patients never noticed, but we would see AST, ALT. Here, normal range was about 40. We'd see it go up to maybe 200 and then back down on its own within a month. And so that did not really change. The decrease in neutrophil count and hemoglobin was a little bit, not enough to need transfusions on this study, but at the higher dose, 2,500 milligrams per meter squared for brain tumors, we have seen a small number of patients that have required the hemoglobin to decrease to the point needing a transfusion and a dose reduction. With the dose reduction, they don't need any more transfusions. So that first data, was very encouraging, and then but the FDA said that was not enough to move forward with approval. We really needed we questioned the equipoise of doing a randomized clinical trial, but the time that it would take to complete enrollment would be another 10 years, and the number of children that would die during that time, if this is real, would be significant. And so the question was, is there another way to look, a more statistically rigorous way to look at the data to see if we could make a determination if this effect was real? So what that involved propensity score matching. Propensity score matching reduces bias when you're comparing patients from different data sources. It matches patients from your cohort to using a score to optimize the similarity of the patients in the cohort group. So we're able to take, for one of our patients, could we find 3 patients in the cohort group that matched, that were similar in all characteristics to our patient. It balances the covariates between the treated and control group and reduces any confounding factors to better isolate the treatment effect. And so we spent almost 6 months talking with the FDA about what are the factors that we would want to match: the age at high-risk diagnosis, the response at the end of immunotherapy window, pre-transplant response without bone marrow, race, sex, stage, time from transplant to start of immunotherapy, because delays can affect outcomes, time from diagnosis to end of immunotherapy, again, delays, so we minimize any delays, time from start to end of immunotherapy, the transplant type, did they get a single transplant, a tandem transplant? And then the MIC-N was matched 100%. So we were able to find, for instance, for each MIC-N amplified or MIC-N non-amplified patients, 1 patient treated and 3 patients in that control group that matched this person. In doing so, we can see that the population characteristics improve significantly with matching. They're almost exact populations now. And so definitely better. And when we look at statisticians, then again, this is a very rigorous look at hundreds of different covariates, but the covariates prior to matching had outliers, but with matching, all covariates that we looked at were within 0.1 standardized standardized difference. And so in doing so, propensity score match confirmed an increased event-free survival with the 90 patients compared to 270 patients, 1-3 match. We saw, again, the same, very similar results with the DFO match group, 84% with no DFMO, 73% event-free survival, and overall survival 96% versus 84%. So even a little bit better. So this significance, and that just continues even out as you go further. If you can look here at 8 years, the difference just continues to spread because the patients who don't get DFMO continue to relapse even past that time. And so they did a summary analysis of many different comparisons. Again, every comparison that was done, the subgroups of MIC-N, non-MIC-N, et cetera, all show significant outcome improvement. These are additional sensitivity analysis, removing patients if the time to start of DFMO. And again, every analysis that was done, if it's on the left, favors treatment with DFMO versus on the right. And every analysis that this FDA and the statisticians did confirmed FDA approval. And we received FDA approval on December 13th of 2023. The medication is now called Milton in the United States, and really based on the children that inspired us to continue this work. Will was the little boy on the phase 1 trial. This is back when he was 11. That really, his father actually raised, while he was on the phase 1 trial, his father, Pat Lacey, raised the money to fund our phase 2 trial. This trial would never have happened without him, and we're incredibly grateful. And his father obviously is incredibly grateful that this medication saved his son's life. And then Finn is a little nephew of the vice president for US World Meds, the company who agreed to help us move this through the FDA because we weren't able to do this on our own. We needed a company willing to do that. And pediatric cancer is not, is not a big moneymaker in the pharmaceutical industry in the United States when there's only 350 high-risk neuroblastoma patients a year. But the fact that her nephew was able to benefit from DFMO as well really implored the company to work with us and help us get this medication through the FDA. And so in their honor, the name of the medication is IWelfin. And the indication the FDA approved this for is for high-risk neuroblastoma patients after immunotherapy in remission. So DFMO, my battery's running low, shoot. 1 moment. Just plug in. I'm so sorry. I don't want to lose you. DFMO is cytostatic by targeting cancer stem cells, inhibiting tumor formation, both in vitro and in vivo models, and preventing relapse and increasing survival in children with high-risk neuroblastoma. I just want to talk a little bit about what is coming next. We have a clinical trial that we're moving forward with, which we hope to be open by the end of June. DFMO, how can we do better? Because there are still some children who are relapsing. So DFMO here again blocks ornithine decarboxylase, ODC, within the neuroblastoma cells. So it cuts off the neuroblastoma cell's ability to make polyamines. But the cell can still get polyamines through a polyamine transporter. New medication, AMXT-1501, is a novel polyamine transport inhibitor. It can block this. So if we block the cell's internal ability to make DFMO and make polyamines and block the cell's ability to take up polyamines from the circulation, then the cell then can become starved from polyamines. So could this increase the efficacy of treatment? When we combined in 3 different neuroblastoma cell lines, the cells treated with vehicle, AMXT, and DFMO in lower doses here, we showed that while the cells continued to grow, the cells treated with the combination were unable to grow. Again here. And when we looked at cytotoxicity, we saw that they were synergistic when given together. We also looked at the amount of polyamines within the cells, and we were able to show that the combination decreased polyamines within the cell and decreased cell viability. This has led to a new clinical trial. We're looking at, I can't see everything, but a phase 1/2 clinical trial with DFMO and AMXT for the phase 1 portion, followed by a randomized controlled trial of DFMO with or without AMXT for neuroblastoma, but not randomized for the other tumor types. I'll be the study chair. Dr. Kraveka will be the neuroblastoma study chair. And then we have other experts in both ETMR, ATRT, Dr. Hansen, in DIPG, Dr. Belamowitz, and then in sarcoma, Dr. Mitchell and Dr. Hoekstra. So this phase 1 trial will be primarily to evaluate the safety, tolerability, and recommended phase 2 dose for this combination. And then once we determine the optimal phase 1 dose, we're going to treat all patients together. A phase 2 will be to really evaluate the activity of AMXT in combination with DFMO based on progression-free survival and overall response rate, and to also look at the pharmacokinetics of AMXT and DFMO in the blood as well as the CSF. So we're going to be looking at the in the phase 2, 4 different tumor types: refractory relapse to neuroblastoma. Again, these are going to be patients either with disease or in remission, and then as well relapsed refractory ETMR, ATRT, DIPG at the diagnosis after standard of care radiation therapy. They'll have a window which they can then enroll onto this combination. And DIPG is one of the most challenging diagnoses that we have, really looking for more options. There was a group in Australia, Dr. Ziegler and Dr. Haber, who studied this combination in DIPG mice and showed a significant improvement in the animal models with the combination of DFMO and AMXT. And the final group is based on Dr. Loeb's work at Montefiore that studied Ewing sarcoma and osteosarcoma using DFMO alone and showed significant improvement. And so we're going to bring everyone together into one larger trial. And I want to just share there are a lot of biological correlates that we're going to be looking at, including polyamine levels, Lat7, as well as circulating tumor DNA and the effect on the immune system, because DFMO also does improve the immune system. So for the 4 different cohorts, only the neuroblastoma cohort will be randomized, because we do know that DFMO does have effect in neuroblastoma. So patients will be randomized to receive either DFMO or DFMO-MXT. Again, these are going to be both oral medications. So especially in the phase 1 portion, while they will need to be here for the initial part, they will be then able to come back and forth to China or to any other country while they're receiving these medications. If they're randomized to Arm B, they will get evaluations every 2 to 3 months. If they do have progression of disease and if it's minimal and would like to try adding AMXT to that, they can cross over, because they will have met the primary endpoint of event-free survival. We'll have that data. And so then they will then be able to cross over and receive AMXT. So everyone has the opportunity at some point on study to receive AMXT with continued evaluations every 2 to 3 months up until the 2-year time point. So we do have other clinical trials that are currently ongoing with DFMO as well. We have just an expanded access study for any Lin28 or MICAN overexpressing tumors or neuroblastoma, but that also then includes those other tumor types that I mentioned. And this is to help patients who are in countries where they're not able to yet access DFMO, while in the United States it's approved and can be given through insurance now. We do have many countries that don't have that access, so they can come here and get medication for free on trial. And 014 study is a continued maintenance therapy. We're looking at the standard dose of 1,000 milligrams, comparing it to the higher dose of 2,500 milligrams. Again, kind of like the DFMO-MXT trial, while many kids are in remission with DFMO, there is still 15% that are relapsing. So we want to see, does giving a higher dose increase that and make a difference? Our 012 study is a randomized clinical trial, randomizing DFMO during immunotherapy. So during that 6 months while patients are getting immunotherapy after transplant and radiation, we're randomizing to get either immunotherapy alone or immunotherapy plus DFMO. We do know that there's about a 14% relapse rate during immunotherapy, even before you get to the end. So we want to see if we can decrease that relapse rate. We do have a study for relapsed refractory neuroblastoma with oral etoposide. This is again for patients who are back in remission. The active disease cohort is closed at this point. That's been enrolled completely. So if patients are in relapse or refractory neuroblastoma and then are back in remission, they can enroll in that study with etoposide. And then we have a study for medulloblastoma patients. It's for ultra high and high risk medulloblastoma, so grade 3s and 4s. And this is a very select patient population. If you have one of these patients, we'd love to talk to you, because it's really finding those patients that have that MICAN that really may have a poor outcome for high risk and ultra high risk medulloblastoma patients that may benefit from DFMO. And that is the DFMO story to today. And thank you again for all of your time and for your interest, and thank you for sharing so many of your patients with us that we're seeing here from China. It's been such a pleasure to collaborate with such wonderful families. Thank you.
Yeah, thank you, Dr. Sholler. Very informative and encouraging result. So we'll leave the questions at the end of the discussions, right, at the presentation. Thank you. So Dr. Yun will introduce our next speaker.
Okay, thank you, Dr. Chen. And I'm very happy to introduce next speaker, Dr. Jacqueline Kraveka from the Medical University of South Carolina. Her topic today is latest developments in neuroblastoma therapy in the U.S., introduction phase strategies, in incorporating GD2's targeted immunotherapy. Please, Dr. Kraveka.
Good morning, everyone. I'm very honored to be here and to participate in the seminar with you. I'm going to share my slides, and I believe you should be able to see them now, and I'll go on to full screen mode. Can you all see my slides?
Yes, it's okay.
Great, perfect. So like I said, I'm very honored to be here today, and I'm just going to talk a little bit of background regarding treatment of neuroblastoma in North America and the new approaches that we're undertaking. So these two slides show, first one is event-free survival, and then later overall survival of children treated on children's oncology group trials looking from 1990 to 2019. So we have made a lot of advances, but if you look at event-free survival, it's now a little bit over 60%, whereas in the 1990s it was less than 30%. So it's, with advances and intensification of therapy, we are doing better, but unfortunately, a lot of children are still relapsing, and we need to do more so that these children have a long-term life. And this is just kind of a scheme like Dr. Sholler had gone over, looking at what the current standard of care is in North America for induction chemotherapy, which consists of about 5 to 6 cycles of chemotherapy. And for patients who have a poor response, they may receive additional cycles of chemoimmunotherapy. During induction, patients have their stem cell harvest performed, they have surgery for the primary tumor and any soft tissue metastatic disease formed at the same time. And then most patients undergo consolidation or stem cell transplant. And in most cases, it's either single transplant or tandem transplant, in most cases, and radiation therapy. And then that's then followed by post-consolidation immunotherapy, usually with dinutuximab. And then now that DFMO has been approved, patients also will then receive DFMO maintenance later. So a little bit about really an important study that kind of guides treatment in North America was ANBL 0532, which really asked a question, are 2 transplants, better than 1? And, in this study, patients were randomized to receive single transplant with CM, which is carboplatin, etoposide, and melphalan, versus tandem transplantation with diotep and cyclophosphamide, followed by a reduced CM, regimen. And this trial used a novel induction regimen, which was based on the Memorial Sloan Kettering N7 backbone. And it's really the backbone that we use in North America today, which is 2 cycles of cyclophosphamide and topotecan, followed by a cycle of cisplatin and etoposide, and then cyclophosphamide, doxorubicin, vincristine, and then the cycles repeat, as you see here. And the one of the things that's important to look at is what was the Indev induction response rate, and what was published. And when you looked at considering the 1993 International Neuroblastoma Response Criteria, is that this backbone at the time was the best that was available, that had a CR but plus VG prior rate of about 43%. And this is just to review the 1993 INRC. We are now using the 2017 INRC, but this study, the 1993 NRC, was used at the time. And there are a little bit of subtle nuances, which I won't get into, between 1993 and 2017. I think 2017 is definitely much more comprehensive, but in order to look at the literature, it's important to highlight, what that was. So, what this study showed, that tandem transplantation improved event-free survival, and the 3-year EFS was 62% for those patients who underwent tandem transplantations versus single. But if you look at really overall survival was not statistically significant. And the benefit in event-free survival was really even more remarkable for those patients who received anti-GD2 immunotherapy post-consolidation. And if you look at what was published, the EFS for those patients who received immunotherapy post-transplantation was 73% versus 55%. But again, there was a trend for an improvement in overall survival, but still the OS not being statistically significant, probably due to some patients, still relapsing. So a lot of patients are still, they relapse, but they're living with disease. And obviously, we really need to do something better to help prevent these children relapse and really have a sustained event-free survival and overall survival. So just briefly about anti-GD2 immunotherapy. So GD2 is a glycosphingolipid. So it's a fat with a sugar on it that's highly expressed on the surface of neuroblastoma cells. There are several anti-GD2 antibodies that have been developed. In the US, we use dinutuximab and exitamab, and in Europe, dinutuximab meta. St. Jude also has their other antibody as well. And the landmark study ANBL-003 to randomize children to receive either cysteine acid alone or isotretinoin after transplantation, or a combination of dinutuximab, GM-CSF, and isotretinoin. They really demonstrated an improved EFS of 66%. And over time, we see that that kind of decreased a little bit. So some patients relapsed later, but the results of this study really made the use of anti-GD2 immunotherapy post-transplantation really becomes standard of care. And similarly, trials in Cytopen in Europe with dinutuximab beta showed improvement in EFS and OS post-consolidation. And then we are using the combination of dinutuximab with irinotecan and temozolomide for patients with relapse or refractory disease. And then exitamab, which I'll talk to you a little bit about, is a humanized 3F8 antibody. The results were recently published, and it was FDA approved in 2020, demonstrated an overall response rate of 50% with patients with residual disease in the bone and bone marrow. And one approach that we've been using for patients up front who have a less than complete response is bridging, what we call bridge or salvage therapy with chemoimmunotherapy, with usually dinutuximab, temozolomide, and then some centering with chemoimmunotherapy. A little bit about the anti-GD2 antibodies that are in clinical trials in North America. So the dinutuximab is the chimeric 1418 antibody, and then exitamab is a humanized monoclonal 3F8 antibody that was developed at Memorial Sloan Kettering Cancer Center. And this kind of just shows a structure, for you all. And a little bit about differences in these two antibodies. And the reason I'm going into this, that are being conducted within our Beat Childhood Cancer Research Consortium, then also in the Children's Oncology Group as well. Dinutuximab is a chimeric monoclonal antibody. It was approved in March of 2015, and it's given at a dose of 17.5 milligrams per meter squared per day over 4 days, given every day. And it's a long infusion. It's about 10 to 20 hours. Both antibodies are characterized by pain. It's a patient-controlled anesthesia or a pump with morphine is often indicated for dinutuximab. And exitamab is a humanized, it's commercially known as Danyelza. It was approved in 2020 for patients with relapse and refractory neuroblastoma in the bone or bone marrow. It's given a little bit differently at a dose of 3 milligrams per kilo per day on days 1, 3, and 5. And its infusion the first infusion is given over 60 minutes. and subsequent infusions are given over 30 to 60 minutes. It's given in combination with GM-CSF, and the time of pain is short. So the PCA is not indicated. Now, if both antibodies have very similar infusion-related reactions, dyspnea, bronchospasm, and anaphylaxis, severe neuropathic pain, peripheral neuropathy, transverse myelitis, and reversible posterior leukoencephalopathy syndrome. This just a little bit, shows you the original schema in the ANBL-0532 study with dinutuximab as a tretinoin, and it consisted of 5 cycles of immunotherapy and 1 cycle of isotretinoin alone. Interleukin-2 was originally given cycles 2 and 4, but was discontinued after the HR ANBL-Ciopen trial reported increased toxicity and no advantage with IL-2. So it's now given post-consolidation with no interleukin-2. And one of the things that I think, has been, very exciting was the work by Dr. Furman's group at St. Jude, where using that same backbone that I talked about in the COG studies at ANBL 0532, that modified N7 backbone, they added their own antibody, which is HU1418K332A, which is a modification of that to induction therapy. And what was really exciting was that their VGPR plus rate, which was using the INRC criteria, the patients who had a CR plus VGPR was about 68% versus 43% in 0532. And they're kind of listed here. They're patients who had more than a PR rate were over 95%, and the primary tumor volume decreased by a median of 75%. And what was exciting to us as well, we really all believe that if you look at several studies and that have looked at is that the end of induction response really will correlate with EFS and OS. And this is just a slide from Dr. Pinto's paper in 2019, looking at how the end of induction response correlated with superior EFS and OS across 4 consecutive COG trials. If you look at also a recent publication by Dr. Desai in 2022, also showed that end of induction response in the patients who were enrolled on ANBL-032 correlated with outcome. And, looking at Curie score as a surrogate for disease, Dr. Yannick published results from the prior COG study, A3973, that showed having disease burden or having active disease prior to transplant correlated with worse outcome. And in that study, patients who had a Curie score that was greater than 2 had a much worse outcome. And if you're NMIC amplified, you can see that survival was very little. So really, one of the things that this really showed is really it's important to have that best response prior to consolidation. And for patients who still have active disease, then doing transplantation, giving transplantation, really does not improve outcome. And this was also validated across Ciopen studies using the Ciopen MIBG staging in patients both treated in COG studies and in Europe as well. And this really showed that also correlates with disease burden and improvements in outcome. I think my computer may be stuck. And then more recently, Dr. Schreiber published an analysis looking at 0532 and looking at that impact of end of induction Curie scores, and really showed that, again, patients, for example, patients who had a Curie score everything that was greater than 0 had a superior EFS of 73% versus 46%. And patients with NMIC amplification did worse as well. So, the thought was what can we do to really decrease that disease burden? And, so in our Beat Childhood Cancer Research Consortium, we have an ongoing study that I'm the study chair of BCC 018. These just show our sites in North America. And we are using kind of the backwards of the current COG induction schema, which is now 5 cycles instead of 6. It's that same backbone that was used in prior studies. And the reason is, why are we not doing 6 and doing 5? Was that 2 pilot studies show that there was, and this way we're exposing our patients to less anthracyclines and less potential cardiotoxicity. And it's now 5-cycle induction backbone has become the standard of care in North America, for children. And then this is our schema in our BCC 018 study. We're adding naxitamab, which is the humanized 3F8 antibody, commercially known as Danyelza, to induction therapy for patients with high-risk neuroblastoma. These are the cycles shown here. Patients typically undergo stem cell collection after cycle 2, and then undergo surgical resection after cycle 4 or 5. And the BCC 018 study is solely an induction study. Patients then, after BCC 018 go on to consolidation, and that's at the treating physician's choice, institution's choice, whether they undergo single or tandem transplantation, because some centers will still do single transplantation, and then they go on to maintenance immunotherapy with DFMO. And we have a randomized study, NMTRC 012, which randomizes patients to start DFMO at the beginning of immunotherapy, and all patients receive DFMO post immunotherapy. And again, this is a single just induction study. And this was our primary objective here, which was to evaluate the complete response rate and very good response rate according to 1993 INRC, at the end of induction in subjects with newly diagnosed high-risk neuroblastoma. The reason we're using 1993 is because we want to compare to that historical control. And I think my computer froze for a second there, and I apologize if my internet connection is not very stable. We have some key secondary objectives, which is to also look at the objective response rate, and also compare it to the 2017 INRC criteria as well. A little bit about naxitamab. Naxitamab is the humanized anti-GD2 3F8 that was developed with Sloan Kettering. And it has a certainly distinct CDR region that was shown to bind GD2 and trigger cell death via ADCC and CDC in vitro. Its safety and efficacy were evaluated in 2 open-label single-arm trials in patients with high-risk neuroblastoma who had disease in the bone or bone marrow that was studied to Dr. Mora and received first approval in November of 2020. And this shows the structure of the naxitamab molecule. This shows our overall schema and treatment plan for our patients. We are performing whole exome, whole transcriptome sequencing and all tumors of diagnosis. The naxitamab is given at the standard dose of 3 milligrams per kilo per day on days 1, 3, and 5 with GM-CSF. And then, which is continued on day 6 through 10. After day 10, another growth factor may be continued. As sort of the standard of care, peripheral stem cell collection is done after cycle 2. And then we're obtaining tumor evaluations every 2 cycles. That includes CT or MRI, MIBG scan, PET scans for those patients who are not PET avid. We're going to look at response by both 1993 and 2017 INRC, and surgery scheduled to occur after cycle 4, but could be delayed if needed. And then we include a bridge therapy for patients who have a poor response to induction. And kind of we're doing an amendment now where patients can receive up to 6 additional cycles of immunotherapy per what's called the HITS regimen. And HITS regimen is a combination of naxitamab with irinotecan and temozolomide. And really, we're characterizing poor responders as any patient who has a Curie score that's greater than 0 at the end of cycle 5, or any positive bone marrow element. So a little bit of error on the slide there. So if you have a Curie score of greater than 0, you go on to receive bridge therapy. We are reporting on the safety of our first 7 subjects at the ENR meeting, and I hope to hopefully meet some of you there in the next 2 weeks, if possible. And we have more patients now. That was data as of March 2024. We actually have more than 19 patients have received protocol therapy, and 15 have completed it. We have over 241 naxitamab infusions administered, and when we've seen the common expected side effects of anti-GD2 immunotherapy, which in grade 3 side effects include pain, hypertension, hypotension. Some grade 4 AEs included dyspnea, decrease in neutrophil counts and platelet counts. We had no fatal AEs, and there were no new safety concerns that emerged. And we've seen really good safety with a combination of naxitamab when combined with immunotherapy, and found that it was really found to be manageable, and acceptable. I'm going to talk a little bit about the current upfront trials, COG trial, ANBL 2132, and the COG initially did a pilot study. Dr. Federico, who was one of the authors and worked with Dr. Furman at St. Jude with the St. Jude study. And the COG pilot ANBL 17P1 was a pilot study looking at safety and the tolerability of dinutuximab when combined with chemotherapy during cycles 3 to 5. They have 42 patients enrolled. There were no safety concerns that were seen, and the preliminary results of this study were presented at the 2022 ASCO meeting. This study looked at the 2017 INRC, and when they looked at the objective response rate, which included both CR, PR, and patients who had a missed response, it was 86.8%. This is the schema for the current COG study, in which patients all get the first cycle of induction chemotherapy with cyclophosphamide and topotecan, and then they get randomized to receive dinutuximab with cycles 2 through 5, and they include patients to receive an extended induction, and they have a definition of whether they're a good end of induction response or a poor end of induction response. So a little bit different. Our 018 study is you receive salvage chemotherapy or bridge chemotherapy if you have any Curie score that's greater than 0 or any positive bone marrow involvement. This has a little bit more nuances, that you receive bridge chemotherapy if you are less than the PR, and kind of the criteria for what are called GEAR and PEER are shown here on this slide. In this study, the extended therapy is with dinutuximab, irinotecan, and temozolomide. A little bit of the design differences: the ANBL 2131 study is a randomized study. It's a phase 3 study. Its primary endpoint is looking at EFS. The study not only includes induction, but goes through induction, tandem transplant for consolidation, and then dinutuximab immunotherapy. Patients will receive the anti-GD2 immunotherapy cycles 3 to 5. And then our BCC-018 study, it's a single-arm, non-randomized study. And what we're looking at is really at the end of induction response. As secondary endpoints, we will look at EFS, and the criteria for bridge therapy, is a little bit different. In 018, we received naxitamab up front during induction, and perhaps in the later immunotherapy, we recommend dinutuximab. And perhaps we don't know, is there an advantage of possibly receiving 2 antibodies post consolidation? This is just a little cartoon, just to kind of highlight the differences in 018 when or not do you receive bridge therapy versus the ANBL 31 study showing when those patients receive some bridge therapy, as well. I just want to, we thank our patients and our families participating in this research, and thank you all for allowing me to speak on this topic.
Okay, thank you, Dr. Kraveka, for your excellent talk. We will have the discussion after the next speaker. Let me introduce the chair, Dr. He from People's Hospital of Hunan Province. 贺教授你好，请您主持下一个环节。
So please moderate for the next session, and thank you very much for the invitation of the conference. And for the next speaker is actually from China, Professor Zhang Yizhuo from Yat-sen University Cancer Center, and her topic today is for the application of it's like a microbiome in the GD2 antibody therapy in the MB. So let's pass the floor to Professor Zhang Yizhuo. Thank you very much, Professor He, for your introduction. And because that we do have many of our Chinese physicians online listening to this presentation, so in order for them to just like listen more clearly, and I will speak in Chinese. And specifically, thank you for our 2 professors from the US and the Professor Chen from Hong Kong, and for your just like support for the meeting. I'm gonna share my screen now. Can you see my screen? Yes. Yes, so thank you. I would like to start. And I think I'm very happy to like hear from Professor Sholler and also Professor Jacqueline, and to share about what they have practiced in the US regarding to the studies of the DFMO, and also for the studies regarding to this like naxitamab and also dinutuximab. And today my topic is from our Yat-sen University Cancer Center. The study is like conducted in our own center, and then we have been delegated our work into the research of the MB in the recent years. So for our clinical part of the work, we are using for this naxitamab combining with PD-1 to treat for the neuroblastoma. And for the starting point is that because we see overseas that there are studies focusing on this like a preclinical study, and have identified that MB, and also for these like 1418, and also for this like for this like a lymphocyte, actually if we having for the co-culture for the expression of the PD-1 is increased, and for this like for this like nivolumab can actually having for, and it can just like improving for this the suppression effect. And then we can see that it can having a more robust effect accordingly, and also to further just like inhibiting for the proliferations of the tumor cells in the MB patient. And also in the Europe, we can see that this is a report from Germany. And then they're using for this like a dinutuximab combining with PD-1, and then to treat the patient with relapse. There are two cases in here. One is a kid like 4 years old. After the treatment, the patient has received the CR, which is a like complete response. And then we can see that after for the treatment of the combination by it's like a dinutuximab and also like a PD-1. Actually, you can see very good outcome. And again, this is and also this is for the second case, a 17 years old teenager adolescent, and then this patient has had 2 episodes of the relapse, and for just like for the relapse again, and then he used for this like basic, just like for those like a monoclonal antibody beta, and combined with a PD-1. And also we can see for this performance in here that the patient has get a very good PR. And then for the preclinical animal study has also dedicated for its effect as well. So we can see that for the study in here have said that for the clinical analysis of this for this naxitamab in the treatment of the pediatric high risk or like refractory relapse MB. And then for the inclusion criteria as showed here, and also we are studying for the ORR, and secondary endpoint is for the DCR, PFS, OS, and AE. And as like Professor like Jacqueline has mentioned, their study of it's like a naxitamab, and then and also has like submitted to the 2025 annual meeting, and the same as us. I mean, like we also have submitted our research to this like 2025, just like our meeting. And this is for our patient like group, and then we have 18 patients enrolled to the study, and then we can see for the basic characteristics, for the baseline characteristics, and then we can see for the age as shown in here, and also for the gender, and for the age of diagnosis, and also for the like just like a grade of like differentiations, and also site of like a primary origin. And also we have seen for this like a MYC-M non-amplification patient that we have like just 13 of them. And we have 3 cases of the for the second MYC and amplification, and the 2 cases of the MYC and gain. And also we can see for the disease status before treating with GT2 antibody, we have a 3 patient has received the CR1, and we have like 11 patient have like refractory diseases. 4 of them have progressive diseases. And also we can see for this evaluable lesions, like just like 12 of them have like evaluable lesions, and for these like a stem cell transplantation because of some just like characteristics in China for the like acceptance of the transplantation in the population is not very similar with those like a Western patient. So we do can see that we have like much more patient has not undergoing for the stem cell transplantations. And in here we can see for the treatment and the response, we can see for this just like a regimen as shown here with like a naxitamab plus PD-1 antibody, 6 patient. We have like a naxitamab plus chemo plus like PD-1 antibody. We have like 12 patient. And also we have for this like a post-maintenance treatment, 2 of them using for this naxitamab, 4 of them using naxitamab combining with DFMO, and the 2 patient is using this like lorlatinib. And also we are trying to evaluate for the like applications of this GD2 antibodies in our China, just a Chinese population, since we know that DFMO has already approved in the US by the FDA, as like Professor Sholler has mentioned, and we look forward to have access to the DFMO in China soon. And in China, that we are also having some just like a special, just like a structural part. Just for example, in this Hainan, we having for this like access zone, and then they can have. For this privilege to use those overseas approved medications, but only in that area. So that we can see this is for the safety of the PD-1 antibody. For the overall safety is good, and for the common adverse events were like thyroid function abnormalities. We can see that actually for the overall like outcome is quite satisfactory to us, and mainly is like impacting the patient's like thyroid function abnormalities. So we had we had 2 patients with elevated T3 and or T4, and then we have 3 patients have decreased T3 and or T4 or evaluate for like elevated just TSH. However, all of this adverse event is like controllable and also manageable. And then let's look at the survival. For the median follow-up time was 18.9 months. And then we can see that for all patients, for the 12-month PFS and OS were 82.6% and 94.1% respectively. And even though that for the sample size is not a lot, but however, that we are still doing a subgroup analysis to the patient. For the CR patient, we have 3 patients that have CR, received a CR. And for the refractory disease, is just a group that we have 11 patients. We have 4 patients in the progressive disease patient, just a group. And then we can see for the 12-month PFS rate for patient with CR, refractory, and also progressive disease, 100%, 90.9%, and 37.5% respectively. For the OS rate, is like 100%, 90%, and 66.7% respectively. And then we are like expanding our sample size. But however, we can see for this like just like a dominant patient subtype is still for the MYC-in for this like a MYC-in just like non-amplified. And then we can see if comparing with for the MYC-in amplified and also non-amplified just a subgroup, we can see for the like 12-month PFS rate for patient comparison was 86.2% and 66.7%. And for the OS rate comparison is 92.9% and 66.7%. We can see that by using for the combination therapy, but still we can see that for the trend is like quite differ. And then for this part, like a short summary is that this is the work that we have done before, and for the regimen containing for this like naxitamab combining with like PD-1 antibody was safe and also tolerable. And for the patient with a refractory relapse and progressive like MB, for the treatment regimen containing for the naxitamab and the PD-1 antibody indicated like a preliminary efficacy and warrants for the further follow-up, and also we need to expand for our sample size, and then we need to provide more and also a more like potential like opportunities. And for the second part is actually what we have done in our University Cancer Center, and this is actually the publication that we have been selected as just like a poster presentation in the 2025 NLR. We know that for this, like for the microbiome, in fact, in recent years, whether it is a like benign disease or like malignant disease, in the recent years, there are like many of the research focusing on this area, and especially when in terms of the efficacy of the immunotherapy, and we need to see whether it will impact for the efficacy and safeties of the IO therapy. Just for example, for the patient receiving for the PD-1, And for those like a well-responsive patient, we do see some like positive just like bacteria, and then we can see that such as for this enterococcus, it's like a facialis, and their metabolite butyric acid can promote for the proliferation of the effector T cell and inhibit for the function of the refractory T cells. And also we can see for the excessive proliferation of the harmful bacteria may reduce the immunotherapy response through the mechanisms. And we can see in 2023, December to September of 2024, in our cancer center, we have collected 22 patients sample. And then we have like briefly just like divide this patient into two groups. One is like MYC M positive or like 11q depletion. And the other group is MYC M like negative or like what is like 11q like depletions. And afterwards, we can see we have a like median follow-up of like 12 months. And then we can see that for we have like a 5 patient progression in this like a MYC and positive group, and then in this like a MYC and like just negative like group, then we only have 1 patient that have the disease progression. So we really wanted to see like whether we can have a more individualized like judgment for the patients regardingly.
So here, well, during my presentation, they have so many results of the gut microbiota, those analysis of the omics. Here are some of the methodologies. These are the different subgroups. So we have already predefined. We have the group A as the red one. Those are the samples from the patients with poor prognosis. They are pre-treatment samples. And in the dark blue, these are the samples from the patients without the poor prognosis. They are pre-treatment samples. And for the following two, these are the other groups of the samples. And through the analysis, we found that for the right one, that is group A and group B, their microbiomic differences, and also in the differences of the abundance and the enrichment of the different species of the microbiota. And through this figure on the left-hand side, that is through this weighted unified Proco A, we observe some differences in the species classification between the group A and group B. And also using the beta index, we found there are some differences with the abundance of the different microbiota groups in the group A and group B. And at the phylum level, because we know that there are different levels and different phylums, different species of the microbiota. So at the phylum level, well, in the group A and group B, well, the gut microbiota, we did this different analysis on the differences. So here we found that the Firmicus was the dominant phylum in the gut microbiota of all individuals, consisting of 40 to 60% of all the phyla, followed by the proteobacteria. And in different subgroups of different clinical characters and different outcomes about the differences of the treatment, we found that the group B patients exhibited a decrease in the Firmicus and the bacteriodota, and an increase in the Enterobacteriota and the verrucomycin microbiota compared with group A patients. Well, they include the group B has a higher abundance of Dialister, Hodemania, and Salmonus. They have significantly increased in group B samples. And next, using Life-C analysis and the cladogram, we found that, well, they have 25 differently abundant taxa at different taxonomic levels. Well, among them, 21 were from group B and 4 were from group A. So here for the cladogram, that is the best visualization of the Life-C analysis, we found that compared with group A, well, the actinobacteriota was increased in group B patients compared with group A patients. And then, using the untargeted metabolomics analysis of the species with significant difference between groups A and groups B, we have this volcano map of different metabolites in the ESI negative and ESI positive ion modes. But here for the red ones, they represented the significantly increased metabolites, while the blue, they represented the significantly downregulated, decreased metabolites. And see here on this slide, just through the sequencing, we found the correlation analysis between differentially abundant microbes and their metabolites. So here the red, the green, the orange ones, they represented the positive relations, and the blue ones, they represented the negative relations. So here with the stellar markers, it means with significant differences. So here in group A, in group B, in microbiota, in the microbes and the metabolites, they have significant differences. And then for the static plot of the correlation between the Salmonella and the two metabolites, we found that there is a specific relation between the solimers of the two metabolites of the different amino acids. They have a significant positive relation with the solimers. So here, well, I would give the presentation in this year's annual conference. Well, the first batch of the samples, so we have 40, and in April we sent another batch of samples over 100 stool specimens from over 60 patients. So we see that dialister, that is the microbe that we found have different levels. Well, that is the gram-negative staining microbe. And for the Honomania, that is a beneficial microbe. Well, now we do not have very much studies and data on this species. Well, that is for the homeostasis of the GI tract. And for the Salmonella, well, they would have the functions of maintaining the integrity of the GI tract, the epithelial cells. Well, so for this study, the goal is just through the collection of greater number of the samples and to have a longer following up to explore the gut microbiota, these different biomarkers. Well, on the basis of the genomics and the transcriptomics, these biomarkers, these are the most familiar biomarkers. But for biomarkers from the gut microbiota, we'd like to do some explorations if they would have the influence or they have some relations with the outcomes of the patients receiving this biological treatment. And also based on the multi-omics data from gut microbiota, well, they would help to develop an efficiency prediction model for the GD2 antibody treatment in the NV based on the gut microbiota multi-omics. So I think it just meet the requirements of the trend of precision medicine. And what we want to do more is to enhance the mechanism study to elucidate the specific molecular mechanism by which different microbes and their metabolites to regulate the gut immune environment, like the specific mechanism, like the Th1, Th2 balance and the DC activation. Well, just to transfer the clinical predictive model to a preclinical mechanism study.
Thank you so much.
Thank you for your listening. Okay, and I will end my sharing. Okay, thank you, Professor Zhang Yizhuo, for your wonderful presentation. And Professor Zhang Yizhuo just introduced some studies from Yat-sen University Cancer Center, two clinical trials. One is for GD2 plus PD-1. It's a treatment efficacy in the HRNB patients about clinical application, and also for the gut microbiota, the different species, as well as the metabolomic studies. There are different changes during the treatment of the anti-GD2 immunotherapy. Well, these are really two latest studies. Thank you again. And then for the panel discussion, I will give the floor to Professor Zhang Yizhuo. Okay, thank you for your summary and your introduction. So now let's enter the panel discussion session. So according to the presentations by the speakers from both the US and China, we can do some comments. We would invite all the speakers and the panelists attending the conference today. Well, I would introduce. Well, firstly, please let me introduce Professor Chi-fung from Hong Kong Sanatorium and Hospital, who is very experienced in this area, especially in the area of the application of naxitamab, and also among the authors who have firstly published articles on the application of this antibody. And also we have invited several Chinese panelists in South China, some experts, some very experienced doctors in the area of treating NB, especially very famous in the patients. Firstly, Director Professor Yuan Xiuli from Shenzhen Children's Hospital and Professor He Xiangling from People's Hospital of Hunan Province. They are from different provinces. And Professor Chen Kanlai from Wuhan Children's Hospital, and two of my colleagues from Shenzhen University Cancer Center, Professor Lu and Dr. Wang, and also Professor Zhang from Guangdong Women Children's Hospital, and Professor from Nanjing, from Zhou from Nanjing. So please make your comments on the content of the.
Okay, 陈教授您先请吧。
Yeah. First, thank you, because I was not able to summarize the study and the presentation of Dr. Sholler. So basically, I think we already heard about that. There's a breakthrough and maintenance therapy of neuroblastoma using the DFMO. The main mechanism is the polyamine depletion for this drug. And then it seems it's quite safe, and then it's quite effective. And then, as you can see, for high-risk neuroblastoma, the survival can reach up to the level of around 87% in 2 years. That's very encouraging. And she also mentioned one of the common side effects is hearing impairment, which is 11%, and then actually is self-limiting and can recover after stopping the medication, right? If I understand correctly, that's what you mentioned. And she did mention there's some new advances, further new advances. So one of them is the AMXT1501, which is the blockage of the polyamine transporter from the cell surface, because definitely I think it's a very bright idea, because in the cancer micro environment, even you deplete the cancer cells, but the adjacent cells may provide this nutrient to the cancer cell. So that may account for the resistance of this treatment. Then she also mentioned some of the patients will receive a VP16 together with this DFMO. I think this is also a very nice idea, because the VP16 actually suppresses the macrophage, which is predominantly present in the cancer microenvironment of neuroblastoma. I hope I summarized the key message of you. Anyway, so I can start with the first questions for Dr. Sholler. You mentioned that actually with one of the hot debate about the mechanism of DFMO on the amplified and non-amplified patient. Because the basic science is that the NMIC amplified patient will overexpress the ODC, which is the enzyme that account for this increased production of this polyamine. So, and you told us that actually the survival are similar, but was there any subgroup analysis really compare? Because in the 2022 paper, actually it's from your group also, we did see some difference in the amplified group and the non-amplified.
Yes, absolutely. There's a greater increase in event-free survival with the MIC-N amplified relative, because they start off at a lower than the MIC-N non-amplified. So even they both have an increase, but the MIC-N amplified group does have greater benefit than the patients with non-MIC-N amplified. But
let me even out the two. So both of them has improvement.
Both has improvement, but it takes away MIC-N as a risk factor because that group started off lower, but still comes up to the same.
Okay, another one interesting thing is that DFMO has been used in the sleeping illness in the Africa, and also the hair overgrowth in women.
Yes.
I did see some of the patient with DFMO actually has hair loss. Is it a finding too?
Yes, we have hair thinning. It's true. The only approved indication prior to this in the United States was for DFMO was actually a hair removal cream called Vaniqua that women can use on the lip line. It suppresses the hair growth. And when the women stop using, hair does come back. So they do have to continue using it. And that's what we see in our patients. It has been interesting and sort of an anecdotal finding that the patients who do have hair thinning, it's different than chemotherapy. It's actually more of it's hair thinning throughout the hair, but definitely in the temples area versus a chemo hair loss, which is more, complete hair loss. So it's more of a hair thing, definitely more in the temple area. The patients do, the hair does grow back when they stop using it, just like with the women. So since it's a cosmetic side effect, we haven't changed the dose, but anecdotally, it does appear that the patients that do have the hair sensitivity do seem to have a better outcome as well, which is interesting. Maybe they're more sensitive to the medication, but that has not been proven, and we have not done that analysis. It's not always documented, we've noticed. We try and encourage everyone to document a grade 1 alopecia when we do see the hair thinning. But since it's a cosmetic side effect and it's a grade 1 toxicity, we are really collecting grade 2 and above in the study. So it's hard for us to capture that in that relationship.
One question, the last question for you is that because the antibody was found to be effective if we push it to the induction. And since the DFMO seems to suppress or, kill the cancer stem cell. So will it be more advantage if we put it upfront?
We've discussed that and have wondered about that. One of the concerns about upfront is that there's such a high burden of disease, and DFMO does cause senescence and less activity of the cell, and generally cells are more responsive to chemotherapy if they're rapidly dividing. So we've been a little bit nervous to add it up front because we want the cells to be rapidly dividing while we're giving them the chemotherapy, at least to get the tumor burden down. And then at some point, but we do think at the end of the beginning of immunotherapy, again, by then they should be close to remission. But during those first 5 cycles, we definitely that has had a lot of discussion around that. Good question.
Okay, thank you. So the one question is for Dr. Kraveka. It's interesting to see the result. One of the study in Puerto Rico you mentioned, they put the antibody on the 3rd and 4th cycle induction, right? If I got it correctly. Because in reality, sometimes it's really difficult to give the antibody because of funding or whatever in the first cycle and second cycle. So
it really is. And sometimes the patient is so sick, even in that first cycle, to try to get antibody in, that even in kind of an upcoming amendment for our studies is we allow you, if emergency treatment, to get a cycle of chemotherapy alone first, and then patients will still get 5 cycles with antibody, because sometimes it's often difficult to do. And we're fortunate with the 018 study is that the naxitamab is being provided by YMAB. So all patients, so it's not being, because I know it can be sometimes an insurance issue also.
Yeah, thank you. So I think I will leave the time to the other panelists. So Dr. Zhang, I saw you there. Yeah. Actually, before if nobody, I would like to ask a question of Professor Zhang also. Yeah, it's a very interesting study of the PD-1 or inhibitor together with the antibody. But I saw that one of the arm is plus or minus chemotherapy. Because personally, I think with the chemotherapy probably better. So did you find that subgroup is doing better? Dr. Zhang? Professor Zhang, Yizhuo, are you still there? Or maybe she's busy. So I leave it to the other panelists.
好的，我在的大家可以听到吧？
Yes,
听到。
yes, I'm here. Yes. Because you know, like for this, just like for the chemo, might just like modify for this like cancer microenvironment.
That's why I asked you this question, because I see the two subgroup, right? One is plus or minus. 有加这个化疗，没有加化疗的那个。
好的，我来回答这个问题，因为
Okay, thank you very much. I would like to answer this question because so far today, for the data that I have shared with you, this is for the treatment regimen that for like PD-1 combining with a GD2 antibody and combining with chemo. And in fact, in our cases, we do have the case that's not joined with PD-1. So we have the cohort only receiving the GD2 antibody combining with chemo. I didn't just include this part of the data into my presentation. I didn't cover for the detail, but however, because we are thinking afterwards, we are extending, we're increasing for the sample size, and then we're going to extend for the follow-up as well, for follow-up time as well. And we are going to just like focusing on this group of cases, which is the group of like with this like GD2 antibody combining with chemo and the PD-L1. And I haven't like shared with you for the data, and I only shared with you for this like for the publications or like for the poster publications that we are gonna be presenting in this year's R&R meeting. And I do think that just a GD2 antibody combining with chemo and also combining with PD-1, we do think that for the outcome is going to be very promising. We have a very good confidence on that. So we wanted to further extend the time of the study and also extend for the scale of the trial. So that's why that we didn't have this part of the data.
In the microbiota data, because the chemotherapy definitely may affect the microbiota in the gut. So because it changed the immunity. Because in your group of a refractory disease with the other risk group, I mean, some patients may receive more chemotherapy than they are or heavily treated. So this is a confounding variable. Did you try to look at that?
Thank you very much, Professor Chen. And Professor Chen actually gave us a very good reminder because that was our starting like 22 cases when we are submitting to this like NR conference. We only have submitted with our first batch of the samples, which is only 22 cases. And in this April, we submitted again, like just like around like 60 cases, just like 60 patients, more than 100 like specimens. So it should be at the end of May or beginning of June this year. And this batch of the data will be supporting for the microbiome metabolics data will come back. So I thought we will do more in-depth analysis of more subgroups. So as you just mentioned, for example, in these two groups that just like we have been like documenting for their just like for this like microbiome, and as you have said, for the patient that they have receiving different levels of the chemotherapy. intensities. I think this is also very important, and I think this is a very good point, and which is needed for the further analysis. And I still wanted to keep the data to be published or like to be shared after we get the sample, just for this analysis. After that, we receiving for this like 100 sample like test. Okay, thank you very much for your reminder. Then, thank you. So based on the order, Professor Yuan Xiu Li might not be online, but we can start with Professor He. Professor He Xiangling, because we do have like Professor Chen and also our expert from the US also is joining us online. So I think this is a very good opportunity that we can ask a lot of questions to our experts, especially focusing on the GD2 antibody. Thank you very much. Thank you. And I myself have learned a lot today. For the first one is for the DFMO. And for the treatment outlook regarding to the MB, Professor Sholler have given us a very fundamental and very detailed introduction on that, focusing on the phase 1 and the phase 2 clinical trials. And also she has shared with us for the ongoing and also for the current recruiting clinical trials. I myself have 2 patients with high risk MB and who have participated in the US clinical trials. So in my clinical work, I also follow up with these 2 patients. Their feedback to me is that for the DFMO is quite safe to use. And these 2 patients, both of them is having for some like a hearing loss or just like auditory abnormality. As Professor Scholler's presentation has mentioned for this like hearing abnormality, like just like it's only like 10% or like a 10+%, but it happened on both of my patients. And also just like one of them is actually having quite severe for the hearing loss. And because of that, for this like clinical trial, have adjusted his dose and also lowered the dose. But now for this like hearing function has not improved yet. So I'm wondering for like Professor Sholler, is this like a hearing capability will be like recover afterwards, and how long does it will take? Thank you.
Dr. Sholler, do you understand the questions? You can unmute your microphone first. Yeah.
No, it was all in Chinese for me, so I didn't understand.
Okay, I translate for you.
Okay.
So basically, and it's related to the side effect of the hearing impairment. So Professor Ho has 2 patients who went to your place to receive the treatment, and both of them has this hearing impairment, and one of them is quite severe. So her question is it because you mentioned it's self-limiting and then can recover after stopping the medication?
Yeah, the medication
needs
to be
to
stopped.
ask about that. And because here, I also would like to add on one thing is because even before patient on cisplatinum also will have this. But in US, do your patient receive sodium thiosulfate?
They do not, no.
They did not.
Not consistently, at least. I think some participants who practice, but it's not consistent, definitely. Yeah, there is a question of whether the previous treatment impairs as well, especially if it's high frequency. The DFMO is more in the standard dose. The DFMO does need to be held we often will hold it for 30 days and then restart at a lower dose, and then we'll recheck 30 days later. And even if it hasn't reversed to completely normal, as long as it's not decreasing further and is still at a relatively okay place, we wait. If we see a 20 decibel decrease is when we hold the medicine, and then we can restart at a lower dose a month later, and then we recheck again. As long as it's stable to improve, we allow the families to continue. In other times, we have held it longer to really allow it to recur. But the concern of relapse versus as long as it doesn't continue to get any worse is where we've sort of bounced while they're on the study. So it would.
So you mean
4 weeks, 1 month often isn't enough to fully let it recover. But then the question is the families don't really want to stop because of the risk of relapse. And so we compromise this as long as it doesn't get any worse and they're still able to hear is the goal.
何教授，他是说你可以停30天。
Okay, so like Professor Sholler said that we can just like stop for the medication for 30 days and then we can adjust for the doses and then afterwards actually it will be quite stable regarding to this like hearing function. I also have another question for Professor Jacqueline. And in your presentation, we understand that BCC 018 in the induction phase, there are 5 cycles are all using this like naxitamab. And in your presentation that you have mentioned, after for the 5 cycle, if the patient have not received ideal response, and then they will add the 6th cycle. I'm wondering because for the 5 cycle is already have a quite a robust treatment, very intense treatment. What will be the treatment regimen for the 6th cycle?
So basically, the question is in your study of BCC 18018, you mentioned it's a 5 cycle of chemo with the naxitamab, but if in case the patient cannot, acquire good remissions, you will add on the 6th cycle, and then in that 6th cycle, will you use the similar dose of a chemo and antibody? Because as Dr. He mentioned, initially it's already quite strong. So the one additional cycle, will it really change? What's the experience?
Yes, thank you for your question. What we're doing is that we are doing, they can receive additional cycles of naxitamab with dinutuximab and irinotecan. They can receive up to 6 cycles of naxitamab with irinotecan and temozolomide. So really what's called the HITS regimen, it's just modified, whereas the original HITS, the dose of naxitamab is 2.25, and it's given for 4 doses. We're giving the dose of naxitamab 3 milligrams per kilogram days 1, 3, and 5. So they can receive their evaluate after every 2 cycles. It can receive up to 6 cycles of the HITS regimen. Does that make sense?
对，听得明白吗？那其实它有一些微小的。
Well, actually, there are some of the nuances, just with a different adjustment. It is not only 3 milligram; they use 2.25, so they have some of the adjustment of the doses. Okay, also Professor Zhang Yizhuo, I have a question. Well, so please. Well, in your presentation, well, for the gut microbiota, the studies, well, it just makes me think the case that I'm treating now is also an HRNB patient after induction, not reaching CR yet. So we just give his regimen. We are using the naxitamab. Well, for this child, well, for the irinotecan, the patient is intolerant to irinotecan. So the patient is really easy to get a diarrhea, especially after the surgery. So now using the naxitamab, well, the patient also has the abdominal pain and the diarrhea. Now we use the atropine. And also we use some antibiotics, and the diarrhea is a little better, but still very severe. We also used some of the probiotics. Well, through your study on the gut microbiota, I guess maybe when using some of the probiotics, it also may help the patients, especially patients with adverse events of diarrhea. Okay, thank you so much for your question. Well, I think you are very very sensitive for those clinical problems because now we only have 22 cases, the samples from 22 cases. This is really a preliminary analysis, and in the future we would do the specific analysis. So I have done studies on the gut microbiota. It's a mechanism study in tumors to just the efficacy. Well, I found that there are already studies of this kind when using PD-1 inhibitor together with the probiotics. Well, what about the goal is to reach that to enhance the efficacy of a PD-1? Well, just in the introduction during my presentation, well, for those positive bacteria, they would positively regulate the immune environment to enhance the efficacy of PD-1. So here I have a thought that for the PD-1 and the anti-GD2, both of them, they're immunotherapy. So with the addition of some of the probiotics, well, if at the same time it would release the adverse events of the anti-GD2 immunotherapy and also would just regulate the GI tract microenvironment, I think this is a very good direction. And for Ereticon, this is the medicine that we are very familiar to treat MB. Well, for the reactions to Ereticon, has very individualized reactions. It is related to the different subtypes of the patients. Now, for these genotypes, well, we are also doing the research in the Science and Medical Center. Well, we are doing different genetic subtypings. Well, for the Ereticon, well, we can just, if the responses of the patients to Ereticon is very low, we can just increase the dose of Ereticon. We may adjust these doses. So this is a possible direction of research in the future to do the genomic typing. And also in China, we have two pharmaceutical companies. They have this liposome Ereticon. And in our center, we are also carrying out clinical trials of this kind. Well, before we formally started the clinical trials for an exploration of the cases in the real world, we found that for the liposome Ereticon, well, for the patients using VIT regimen, indeed, it would improve the toxicity. Well, the toxicity of the Ereticon would be lower in the GI tract reactions. So I think that for your patients, if there's a possibility, you can test the genomic subtypes and to change the different formats of the Ereticon to change it to the liposome Ereticon. And also, this is a very good reminder from you that maybe in the future, with the combined therapy with antibody and his regimen, to use the probiotics at the same time if it would improve the efficacy. Well, I think this is a really good.
Explain it to the two overseas speaker because it's a very interesting questions and answer. It's related to the irinotecan associated diarrhea because it may affect the microbiota. Was it advantageous to add on the probiotics? But Professor Zhang mentioned that actually in her hospital, they find out that the irinotecan associated diarrhea has a genotype-phenotype correlation. So they actually will check on the predisposing kind of genes for irinotecan associated diarrhea. And then I think that will be a very interesting direction. So, Dr. Sholler and Dr. Kraveka, is it common for you to find because usually in the relapse protocol we often use irinotecan, right? So how often do you encounter this refractory diarrhea? Mm-hmm.
So I will say we see it quite often, and it does vary from patient to patient. It's really, such an interesting talk on the gut microbiome and with the genotype. I think that's very fascinating, and I think has really some great potential to really help our patients. We have some patients that, sometimes we add atropine, and sometimes even despite maybe adding some antibiotics to help, they still have refractory. What I've done in some patients is actually if I've switched them to give them Cytoxan topotecan with either naxitamab or dinutuximab for patients that don't tolerate it. But I was really fascinated by the work with the gut microbiome. I can't wait to hear more about it.
Yeah, I would agree. Very interesting talk, and we do see it very commonly here. So we often will prophylactically treat with the antibiotics to see if we can avoid that. But
so another, I don't know whether in US you encountered this. One of the interesting phenomenon I find recently is that patients receiving proton abdominal RT actually are more predisposed to this radiation enteritis. So it may be another confounding variable that cause diarrhea. I mean, just that Dr. He, make reference to, because some of your patients, if they receive abdominal RT, they can also have diarrhea. Yeah.
Yes, absolutely.
So any other questions or comments from the panelists? Maybe we can go through the, because we still have 5 minutes, go through the 5 questions. Professor Zhang, right?
谢谢陈教授，谢谢陈教授。今天陈教授还是门诊呢，在香港，然后来参加我们的讨论，非常感谢。
Well, thank you so much. Well,
好的，好的。
okay, so Professor Chen Kailan.
很荣幸有这个机会来这个线上研讨。
So honored to have this opportunity to participate in this webinar, and thank you again for your presentation. So here I have a question to Professor Sholler. Here for the DFMO, well, we see in the maintenance therapy, we use this dose of 750 milligram per square meters, and in our patients, that is doubled. So here in this condition, does it mean that DFMO in the RNR patients for the dose and the time, if the dose is greater, the efficacy would be better? And or because for the RNR patients, if we would adjust the dosage, would it influence the efficacy?
Okay, as Dr. Sholler, Dr. Chen mentioned that she noticed in your maintenance therapy and also the treatment for the refractory patient, the dosage of DFMO actually is double for those patients with refractory disease. So the question is it purposely increase the dose for the refractory patient because the response will be better?
So the both are similar. We are now doing 1,000 milligram per meter squared per dose for both on our 014 upfront and for our relapsed refractory patients. While the 003 was closer to the 750, it is a little bit higher. We do think that there is a dose-dependent effect. Although I have to say on our phase 1 study, well, we did from 500 to 1,500 milligrams per meter squared. 2 of the long-term survivors were in the 500 milligram per meter squared BID dose. So maybe may or may not be a difference. I think they're all, close enough that the PKs are very similar when we did the PKs in the phase 1 that I don't know that it made as much of a difference.
So, Dr. Chen, you get it? Yeah, because actually that's an initial study, but subsequent study, both the upfront maintenance. 对不起啊，我也普通话。他后来的研究呢，这个为期期。
Here for the following studies for the maintenance therapy and for the RNR, they would use higher dose.
研究是低剂量，但后来的。
Well, at the very beginning, it is lower dose, but then it just escalated to the higher dose. Well, okay, the second question would be go to the Professor Kraveka. Well, if the induction therapy itself, for the long-term survival, it would have a benefits. But if it cannot reach the complete response, or in some of the bones or the bone marrow, there are still some residue diseases. So what measures would we take?
That means her question is, if after the induction, be it 5 cycle or 6 cycle, there's still residual disease in the bone marrow. I mean, that is, just partial remission. So what will be your strategy?
Thank you for your question. Generally, then we would either, in the current protocol with residual disease, we would do bridge therapy with nixitamab, irinotecan, and temozolomide. We have a patient who, despite is still having that, you consider irradiating, perhaps, those sites of bone, as well be considered. But we're doing in the current OE to get additional cycles, but this time instead of the standard or temozolomide.
OK， 他的回答是，如果
temozolomide, well, if we're in this condition, we're using irinotecan, using temozolomide, well, some of the patients, they would use a radiation therapy to treat this bone residue disease. Okay, thank you. Thank you. Okay, thank you. Well, we have a really hard discussion, but I have already got the reminder from the organizer. We are already very late, so here for the conclusion. But we still have other panelists, Professor Lu and Professor Wang. They are my colleagues. I would represent them. And Professor Zhang Xiaohong and Professor Zhou Li, well, they are very experienced experts. So here are the two directors. So just do a comment, and then we will conclude our meeting. And thank you, Professor Zhou and Professor Zhang. Okay, so firstly, Professor Zhang Xiaohong. So is Professor Zhang Xiaohong online? Okay, Professor Zhou Li. I'm sorry, because we are so much late. And please just comment and conclude our webinar. Well, thank you for your invitation. Well, I think this is a very good webinar with so many information. Well, maybe post the webinar. I would re-listen to those presentations to absorb all the excellencies. But because time is so limited, well, I still have so many questions. So I hope that Professor Zhang, you would organize more webinars like this kind, and we have opportunities to learn more. So here, because time is too limited, I would save my questions, and I would directly give my questions to you, Professor Zhang. Okay. Well, because we would have a replay for the webinar, and we can replay it like Professor Chen and the colleagues from the US. Well, I think they would not refuse us. So we still have a lot of opportunities to communicate. So
Sholler, for Dr. Kraveka and Professor Chen. I look forward to further communication with you in the future. So thank you so much. So Professor Chen, please.
Yeah, thank you. So I think this is a very fruitful meeting, and thank you for the invitation, Professor Zhang. And I learned so much, and then I also witnessed your very good research, and hopefully, we can have more collaboration in the future. And also for the two overseas, Jacqueline, I will see you in the ANR meeting. So we can discuss on some collaboration, because actually I think in China we have quite a number of patients, and then that can advance the recruitment in a very fast manner. Hopefully we can work together. Okay.
Thank you, Professor Chen. Dr. Sholler.
Yes, thank you so much for Dr. Chen and Dr. Chen for inviting me to join this incredible group. And thank you so much for listening and sharing in our DFMO work, and it's just so great to hear from Dr. Zhang about your work as well, and I was happy to learn so much tonight. Again, we are so thankful for this international collaboration. I'll be at A&R as well. If anyone would like to meet, I'd be happy to get together and have some more conversations about how we can continue to work together. This is, just such a bonus for all of our patients to help them. So thank you so much again for both myself and Dr. Kraveka. We're happy to join you.
谢谢Sholler教授，我们也会 NIR see you in NIR
Okay.
conference. Okay.
See you in NR. Thank you.